shared by email. And then I just have a couple disclosures to review really quick. Let's see. Okay. All right. Okay, so this activity for the continuing education unit is jointly provided by the United Southeastern Tribes and Cardia Services. Cardia is approved to provide these credits. And again, you can receive one unit for attending this session. Dr. Mara received an honorarium from AbbVie Pharmaceuticals for a presentation. He is also a principal investigator for clinical trials for Gilead Sciences, Pfizer, and AbbVie Pharmaceuticals, and a principal investigator for Focus Grant for Gilead Sciences. All relevant financial relationships have been mitigated. And then Emily Field, me, I'm a planner. I have a relevant financial relationship with healthwarehouse.com and Pfizer. Also, all financial relationships have been mitigated. And as I mentioned, upon successful completion of this hour, you can receive one continuing medical or nursing unit. It will be sent to you by email. If you have any questions, please reach out to Michelle Doherty at Cardia, or you can reach out to any of the USET staff and we can forward along your questions. And those are disclosures. Dr. Brown, are you ready for the first presentation? He did join, right? I can't see you now.
Yeah, can you hear me okay?
Yes, okay. So we have 3 presentations today. 2 from Dr. Brown on COVID-19 and influenza epi updates, and then we will conclude with a presentation from Dr. Mara on influenza management. And so here we go. Dr. Brown, I have your
all right,
slide deck up.
I see it. And how's the sound quality?
It's good for me. I will mute myself so I don't interfere though.
All right. Yeah, so I'm just going to do the epi update today because Anna Garrett, who usually does it, is out. And I would like to thank Anna for doing many of these slides. The good ones are hers. The ones that aren't so good are probably mine. But we'll start with COVID-19. And yeah, it's still out there. Next slide, please. So this is just a map from the CDC website showing current hospitalization rates for COVID-19. As you can see, most of the country is in the green. There are some patches of yellow, and up in looks like Montana and South Dakota, there's some red. So those are high rates, but most of the country right now is green, which is good. Next slide, please. So this shows hospitalizations over time. CDC didn't really track hospitalizations prior to August. If you remember, the pandemic started in March. CDC is no longer tracking cases because many cases are diagnosed at home with home tests, and they're not being reported as much anymore. So the best measure rate that we really have for COVID activity is hospitalizations. So you can see over time, there have been successive waves of COVID. And if we'll go to the next slide, the yellow line, I think it's yellow, is deaths due to COVID. And CDC has tracked these since the very beginning of the pandemic. But as you can see, superimposed over the hospitalizations, the death rate is virtually identical in terms of the waves that we see here. So the latest data that we have is from about 10 days ago, the very end of September. As you can see, we did experience a wave of hospitalizations starting back in the sort of late summer. That peaked, it looks like, in sort of early September, and then throughout September, there was a slight trend down. Hopefully that's going to continue. Next slide, please. Just wanted to go back and sort of historically, we had this big, huge wave of hospitalizations and deaths, if you remember the first winter, and that was really before vaccination. Next slide. Then along came Delta that next summer, and Delta was a very virulent variant, tended to make people sicker, and we saw a lot of deaths from it. Next slide. And then came Omicron. And again, there was a huge wave when Omicron first hit the second winter of the pandemic. Fortunately, by then, lots of people were vaccinated. We had some treatments for it. We'd figured out some things that worked to keep people from dying. And so the reason that we saw a lot of deaths from Omicron was just because there were a tremendous number of cases. If we showed the case rate here, that peak would be way higher. We're just looking at hospitalizations. But the first Omicron wave was huge. Since then, we've had some more successive waves. And so we're kind of in the fourth wave right now of the Omicron variant. Next slide. So these are the variants that are currently circulating in the United States. And if you look at this slide, the real take-home message here is that COVID is continuing to do what it's done the whole time, and that is it evolves different variants. One variant will be predominant for a while, and then it's replaced by another one. Right now, the one that's got the highest numbers is one called EG5. Next slide. But the real take-home message is that you see all of these different variants listed, and EG5 is leading the pack right now with about 30% of the total. But all of these are just variants, subvariants of Omicron. So Omicron's been with us now for 2 years, and we have not seen a new variant that's different enough to get its own Greek name. So they're all Omicron, and you notice I've put an arrow next to XBB.1.5. This is the variant that the current updated vaccine was designed it was the pattern for the current vaccine. And it was the predominant variant if you go back 3 or 4 months, but now it only accounts for about 1% of what's out there. Don't worry, that doesn't mean that the vaccine won't be effective. There's pretty good evidence that it has activity against pretty much all the Omicron subvariants. Next slide. So COVID-19 is still here. What do we need to be doing? Well, first of all, the updated COVID-19 vaccine is out. It's in kind of short supply right now. There are 2 that use the mRNA vaccine platform, the one by Pfizer BioNTech and the one by Moderna. And it's gotten a little bit easier to remember who gets it. Basically, it's everybody over 6 months is eligible. Everybody who's 5 years old and over, all you need, no matter what your vaccine history is, you just get 1 dose of the updated vaccine. The reason for that is that 90 plus people, I think it's close to 97% people in the US now, have antibodies to COVID, either from the vaccine or from the natural infection, or in many cases, both. So 1 dose of the vaccine should be enough to up your immunity to COVID. But it's the young kids, the 6-month through the 4-year-olds. Them, it depends on previous vaccination history. And for them, I would consult the CDC website for details.
Got disconnected.
Sorry. Okay. I'm reconnecting. Sorry about that.
While you're reconnecting, Emily, I'll just keep talking here. So just a few days ago, the updated Novavax vaccine was approved. There hasn't been a whole lot of uptake of Novavax, but for people who are just, for whatever reason, leery of the mRNA technology, they shouldn't be, but people hear the term genetic and they get wigged out about it. Novavax uses a different technology. It's the older recombinant protein subunit technology. So at least we do have an alternate vaccine that can be offered. I don't know how available it is, and I don't know that the Indian Health Service will be getting any, but we'll try to keep you updated on that. But for people that want something other than an mRNA vaccine, there is an alternative. So who should get vaccinated? Well, everybody over the age of 6 months, but really try to especially urge the high-risk people to get vaccinated with this new updated version. Also, don't forget about Paxlovid. It's everybody who's high risk or anybody that wants it who has COVID, if they're within the first 5 days, they should be offered it. And there are some alternatives, especially IV remdesivir. It's just a little more expensive and harder to use because it is IV. Next slide. So there are lots and lots of high-risk conditions that make you more susceptible to severe COVID-19. I'm not going to belabor you with going over every one of these. I think most of you pretty much know what these are. Basically, it's anybody who's 65 and older, and it's anybody with chronic disease or immunosuppression for whatever reason. So it's a long list. There it is. You'll have access to these slides after the presentation. All right, next slide. Let's shift gears now, and I'll be happy to take any questions from the audience at this point.
So Harry, just one clarification, because originally in June when the FDA said, like if you got, whatever, if you got your mRNA vaccines, just one dose, like you mentioned.
Right.
Now, at that time, they mentioned if you don't have any doses, it's only one.
Right.
But changed now, right? Or, I mean, if you've never been vaccinated, you would still have to get the 3 doses.
No. Okay, that's if you're a child and you've never been vaccinated, then yes, you have to get more than 1 dose. But for everybody who's 5 and over, even if you've never been vaccinated, you only have to get 1 dose. When I first heard this, I was very confused about it. So I did some investigation, and their thinking was almost everybody at this point has had either they've been exposed to COVID and had the disease, or they've had the vaccine. So even if you've never been vaccinated, most likely you've had COVID and you have antibodies. And so 1 dose of the vaccine is sufficient. So that's a pretty big change, because originally we all had to get 2 to have the primary series. But
right. No, okay, no, you probably are right. Maybe I misunderstood the new. I haven't taken a deep dive on the new recommendations, but there was a lot of criticism when they came up with that plan in June.
Yeah.
Because it wasn't based on clinical studies.
Right.
It was just based on expert opinion.
Exactly. Right.
Okay.
But that is the official CDC recommendation.
Okay, thank you.
Now, it is different for children, though. So for kids who are 4 and under, if they've never been vaccinated, they have to go ahead and get the primary series. And I'm not sure what the thinking is on that. They may be thinking that in that age group, a lot of them have not been exposed to COVID. And so they still need the primary series. That's a great question, though. I had exactly the same question, Jorge. I was kind of skeptical at first, but then when I got the explanation, I was like, okay, that makes sense, and it makes it a lot easier to talk people into just getting one. Other questions about COVID or the updated vaccine? Again, the CDC website is a great source of information, and that's where I go to, whenever I have a question. That's my first place to research. And if CDC doesn't know, then I call Dr. Mira, and he tells me. All right, well, let's go ahead and switch gears to talk a little bit about influenza. This will be a lead-in to Dr. Mira's didactic today. So next slide, where are we with influenza at this point? Well, it's early October. So at the USET Tribal Epidemiology Center, we get a report weekly from the Indian Health Service that is an influenza report. This has been around for years. And it looks at a number of parameters for influenza activity. The other place that we go at the Tech is the CDC's weekly influenza report. So Anna Garrett has listed here all the different things that we look at as we're tracking influenza activity. Next slide. So this data really, just gives us a good general overview of the current incidence, prevalence of influenza. And it also tracks vaccination rates for influenza. This is reported by the MMWR every week. And it doesn't really, for the most part, track influenza cases per se. It tracks influenza-like illness, which is not laboratory confirmed. However, it's been shown that this tracks pretty well with the actual influenza cases. Next slide. So where are we right now? We're at about the same place we were a week ago. Right now, we're not seeing a whole lot. Next slide. This is a map of the country. You can see the dark green means there's hardly any influenza. As it gets more towards the yellow or red or purple, that means it's very high. But right now, we're not seeing a whole lot. Looks like maybe Georgia and New Mexico are a little brighter than the rest of the country. But typically this time of the year, we don't see high rates of influenza activity. Don't worry about that graph on the bottom. That's several years. I guess if anything, go to the next slide. This is vaccination rates so far. As you can see, we're doing pretty good in the Nashville area. We're number 2, just behind Navajo. And, it's still pretty early, so I would expect this rate to go up. Nashville area usually does pretty well every year, although we can always do better. And it's the elders that we really, really need to target, although everybody 6 months and older is eligible for an influenza vaccine. Next slide. This is over the past, this is actually the last year. Those numbers on the bottom are the week number. So that huge peak that you see back there, that was last year's peak that happened pretty early. We had an early flu season last year, and then it pretty well tapered off after January. And right now it's, we're in that flat part. It's the calm before the storm, I'm afraid. Next slide. So any questions about influenza rates in the area? You can always contact us. Anna sends out this report to all the health directors on a weekly basis. And you're welcome to contact anybody at the Tribal Epidemiology Center anytime for questions. We're here to help. And if anybody has any questions right now, I'll be happy to try to answer them. Otherwise, we'll turn it over to Dr. Mira, and I'm really looking forward to his presentation.
Thank you, Harry. Let me share my slides. Okay, can you see them? Yeah, okay.
Yes.
Okay, so the learning objectives for this presentation is to briefly understand the structure of the influenza virus, and that will permit you to distinguish between seasonal versus pandemic influenza, the concepts, describe the clinical presentation and diagnosis, and I'll focus more on this third bullet. And we'll also talk about antivirals for treatment of influenza. If we have time, but I think we will, I'll talk a little bit about post-exposure prophylaxis also with antivirals. I'm sorry, something's okay. So this is just a graph of the influenza timeline and burden in the United States. You know, influenza has been documented since Hippocrates, so it's thousands of years old. But in the United States, the strong data starts in 1918 with the influenza pandemic that killed more than 500,000 Americans. And you can see in the purple highlights are the pandemics that have been gone through the United States. In 1957, we had the H2N2 pandemic, 16,000 people died. 1968 was the influenza pandemic related to pigs, the swine flu. And then we had in 2009 that probably most of you remember this one, which was another H1N1, which was predicted to be horrendous, but it was worse than usual epidemics, but not as bad as the 1918 pandemic regarding mortality, but very similar in the characteristics, and I'll explain that a little bit later. And, you know, in these 100 years, we've gone from not having any therapeutic agents or prevention, and now we have good vaccines and we have good antivirals that we can use to mitigate this. And after COVID, we've gained a lot of knowledge on how to prevent respiratory infections just by other measures like mask. You know, mask is the best vaccine because it prevents all respiratory viruses. Just a reminder. So the burden of influenza in the United States estimated by CDC, and I'm sorry, there's a typo. It's 20, no, it's correct. It's 2021, 2022. And 26 to 50 million cases of influenza were reported. 12 to 14 million of medical visits were not reported, estimated. 290,000 to 600,000 hospitalizations, and 17,000 to 98,000 deaths. So this is a broad estimate because they can't measure everything like they were able to do with COVID. But roughly, just as an average, every year there's about 40,000 people who die of influenza in the United States. And most of the people who die are in the high-risk categories, meaning people that are older, that have comorbidities, or the very, very, very young ones. So there are disparities in influenza exposure, treatment, and outcomes. You can see that there are less vaccination rates among non-Hispanic Blacks and Hispanics compared with non-Hispanic whites. The people with comorbidities are also at a higher risk of having complications from influenza. And people who have less economic income also tend to live in smaller places, and in which the distance between persons in the household is shorter, and it's more easier to get infected. And a big subgroup of these minorities do not have good access to healthcare, and that also places a disparity on them. So it's important to acknowledge all the determinants, social determinants of health and racial disparities that these patients have. When you look at the Native American population compared to the white population, they have 2.7 times higher incidence of seasonal influenza and mortality. They have a much higher mortality during the 2009 pandemic, And regarding COVID, which is a different virus, also had a 2.4 times higher mortality during the COVID pandemic. There's not very many studies done to address why Native Americans have more greater mortality. The only decent study was this case control study of risk factors for death from H1N1 across 5 states, mostly southern states. And this investigators looked at different variables. The ones that showed increased mortality were age, pre-existing medical conditions, smoking, not getting antiviral therapy early enough, barriers to access to healthcare, but they could not find that the American Native population, because of just being Native American, was at higher risk of death. Nevertheless, when you look at the study very carefully, they enrolled 381 patients, and of those, very few were actually Native Americans. So I don't think the study was powered to really look at that difference. They just didn't find a difference. It does not mean that there isn't. So for anybody interested in doing epidemiology research, this would be an important thing to tackle, is to really look at the difference between Native Americans and non-Native Americans and see what the risk factors are. If I would have a guess, I would say that the main one are social determinants of health, lower income, less access to healthcare, or less access to, and access does not mean that you don't have insurance. Is maybe you have an IHS clinic somewhere, but you live very far away and can't reach it. So there are 3 types of influenza viruses. They're called A, B, and C. A and B are the seasonal influenza viruses. C is sporadic, very rare. Flu season occurs every year, and it starts in early October and usually ends in late May. And when a pandemic occurs, and we'll go in the next few slides, we'll see what the difference is when the virus has a big change in the structural proteins in the surface of the virus, change completely, and nobody is immune to the virus, and the epidemic turns into a pandemic. So here's a drawing of the virus. It has 8 RNA segments within this virus, and this is one of the reasons that when 2 different influenza viruses infect the same host, usually we're talking about infects an animal like the pig or some birds, they can reassort themselves, and then these 2 influenza viruses mix and come up with a new structure, and that's the danger. On the surface of the virus, you can see these blue and red proteins. The blue is the hemagglutinin, and the red is the neuraminidase. The hemagglutinin is the protein that it's like the spike protein of the COVID virus. It's the one that attaches to the receptor in the respiratory tract. And these are different types of receptors. They're not ARB receptors, or ACE2 receptors. They are sialic acid receptors. And they are very concentrated in the upper respiratory tract. That's why patients with influenza have a lot of upper respiratory symptoms beyond the lower respiratory symptoms. And that's the reason that it's thought that it's not transmitted by droplets, but because when you have infection in the upper respiratory tract and you cough or sneeze, you emit larger droplets than when you're the infection is occurring in the alveoli or in the lung. The neuraminidase, so the virus attaches through this through the blue spike or the hemagglutinin, but then once it infects the cell, to be liberated from that cell and going to infect the next cell, it needs a protein that cuts it loose, and that's the neuraminidase. And why are these important? Because many of our, not all now, but many of our antivirals inhibit this enzyme, the neuraminidase. And both of these structures are the ones who are antigenic, meaning they produce or they generate neutralizing antibody response, and the vaccines are based on these structures of the hemagglutinin and the neuraminidase. So when look at the right side of the graph, when the virus has very small mutation, it's called an antigenic drift. And that's why you may have a new, a different virus than the year before, but not so different that you don't have certain immunity to it. And that's why less people get infected. But when the virus reassorts its genes with other viruses, like here's the graph, like you have let's say an H1N1 and an H2N2 and an H3N5 or whatever, completely different viruses that may infect the same host at the same time, which is usually a bird or a pig. These segments rearrange, they resort themselves, and you can see that the new virus has a little piece of the other viruses, but it's a completely new virus. And most people will not have immunity against this virus. And this is when the virus spreads more easily and causes more severe disease. And that's when the pandemics are generated. So when you have antigenic drift, which are small changes or mutations, you have seasonal influenza. And when you have antigenic shift, it's when we have pandemics. If we didn't have a drift at all, we wouldn't have seasonal influenza. We wouldn't have an epidemic every year. We would just once you get infected, you have an immune response, and you wouldn't get infected with the same virus. But since the virus changes a little bit, it drifts a little bit. That's why people get infected every year, and you need to get vaccinated every year with the new strains. So the differences between pandemic, the cases are much more higher. You can see in 1918, 30%, almost 30% of the US population got infected. 1 out of 3 people got infected. And in the hospitalizations rates in 2009 were very high, 270,000. The deaths in 1918 were 675,000. The deaths in 2009 were much lower, because people had some immunity to the H1N1 virus, and that's why it wasn't as bad. But the other big difference, that pandemic influenza usually affects younger people, and it happened in 1918, and it also happened in 2009 in both of these pandemics. And it also infects people and causes problems with people with underlying conditions. On the contrary, seasonal influenza, much less people get infected. It's 3 to 10% of the population compared to 30% that may occur in the pandemic. The deaths are lower, but they're still significant. And here, the population that gets mostly complicated is the older people and the one that have comorbidity. So main difference is that you will see young people die in pandemic influenza, and you will not, and you will see more older people die in seasonal influenza. And the reason is because older people still have been exposed to the virus for many decades, and they will have some degree of antibodies. They're not completely protective, but they confer some protection. And young people will not have been exposed as much and basically are immunologically naive against the new virus. So knowledge check, you don't have to respond, it's just in your mind. Small changes in the hemagglutinin and neuraminidase genetic sequences occur almost every year. These are examples of which of the following: antigenic shift, antigenic drift, or pandemic shift. So the answer is B. C. Pandemic shifts exist, but every 50 years, so it doesn't really matter. Antigenic shift is what causes a pandemic, and antigenic drift is what causes every seasonal influenza. So this is not Brian Hendricks, although it has some similarities, but I got this photo from the web. Influenza is mainly spread by droplets because it really infects the upper respiratory tract more aggressively, and that's you produce larger drops when you cough or sneeze. You can also get so masks are really good for protection. It can be airborne in very rare circumstances, but for the most part, just think about droplets. You can also touch contaminated surfaces, and if you auto-inoculate yourself by touching your eyes or your nose or your mouth, that can increase, infectivity through that route. And patients can spread the virus asymptomatically, and usually the people start spreading the virus one day before they become sick, and up to 5 to 7 days after their symptoms have started. And it's important to know that children shed the virus a little bit longer in general, and so they're more infectious. And usually the epidemics of influenza start with the children. So when you start seeing people not going to school, prepare yourselves, because 2 or 3 weeks later, the adults are going to be infected, then the grandpas, and then the people start getting in the hospital. Also, there's been studies that looked at the higher the household number or the larger the family, the higher the the risk of influenza transmission, which makes sense. You're you're in a small environment, a lot of people. And also, it's been studied that time to influenza diagnosis in a family members increases with family size. So this is basically a social determinant of health. Here you're looking at people with less economic income. Sorry for the redundancy. And they have less ventilation in their homes. They get more infected. They have less means to go to the doctor, and so they get diagnosed later. And in the U.S. Census data, it showed that 10.7% of 10.7% of Native American households, and compared to 3.7% of non-Hispanic white households, had multi-generational households. So more people lived in the house from different generations. So symptoms, I'm not going to, you all are COVID experts by now, and I'm sure that you've seen your share of influenza. But the symptoms are here. It's fever, chills, cough, sore throat, runny nose, muscle aches, fatigue, headaches. They're not very different from COVID-19. What I can tell you that clinically, but these things are not useful to really say clinically you have COVID or you have influenza. People with influenza get sick abruptly. People with COVID tend to get sick a little bit. It may take 1 or 2 or 3 days until they start progressively feeling sick. With influenza, you're feeling great, and suddenly you think a truck hit you. It's more abrupt. The other thing is that the loss of smell and taste is more specific for COVID, but it can happen in other viral infections. The important thing in the past was to differentiate this from the common cold. And the common cold does not have systemic symptoms. It only has upper respiratory symptoms without fever, or fatigue or body aches. In children, GI symptoms may be a little bit more common, and sometimes the only symptom. So be aware of that. Okay, let's go to diagnostics. So there's been a lot of improvement, but in the technology to diagnose influenza, but I don't think that all the clinical facilities have caught up with this improvement. So in the past, we would use rapid influenza tests or antigen tests, and they were okay. I mean, that's the only thing we had. But today we have molecular tests, and we actually should not be using antigen tests for diagnosis of influenza. The antigen tests are very specific. So if it's positive, yes, you have influenza, but sensitivity, it's really bad. It's about 50%. So you could use an antigen test if you're only going to rely on a positive diagnosis, but not to rule out a case of influenza. So what we should be using is molecular tests. And they could be rapid tests like the ones we use for COVID, or they could be your standard lab send-out test, or they could be part of a multiplex PCR, which not only tests for influenza, but you can test COVID, RSV, and depending on the complexity of the PCR, you can have a whole panel of 20 different viruses. All have high sensitivity and specificity. The beauty of the rapid test is that you can have a result in about 15 or 30 minutes. If I had my own clinic, the one that I would have would be a 3-in-1 test. Molecular test that with one swab can detect COVID, can detect influenza, and can detect RSV, because you detect the main 3 viruses that you can do something about, meaning there's some form of treatment, and you don't have to swab the patient 3 times. And there are several companies that produce this assay, so that would be my recommendation. And virus isolation, that's just a research technique. It's not used for clinical practice because it takes too long to get the results back. But it is the gold standard of influenza diagnosis. So in summary, antigen only if you don't have anything else, and only rely on the positive results. Actually, if you have an epidemic of influenza, if you're in the season of influenza, and someone comes with typical influenza symptoms, you don't have all you have is an antigen test. If it's positive, fine, but if it's negative, you can still treat that patient empirically for influenza if you are in the influenza season. So what I'm saying is that those rapid tests really antigen tests don't help a lot. So in summary, the diagnosis, rapid antigen tests should not be used. We should use molecular tests. Nothing's perfect in life. They have some pitfalls. I mean, they may not detect all the influenza A's that are circulating, but they usually detect more than 95% of them. If you receive a live vaccine, you can have a false positive test. And remember that adults shed the virus only for about 4 days, 4 to 5 days. So you can still see someone coming in with a really bad case of influenza, meaning a pneumonia complication that occurs late after 5 days, and your molecular test could be negative because the viral shedding has come down, and it's the inflammatory response that's hurting that patient. So have those things in mind. Let's go to antivirals for influenza. There's 3 big classes. The M2 ion channels, amantadine and rimantadine, they don't work anymore. All the viruses are resistant to it. They just have a historical value. So I'm not going to even discuss them too much. The 2 most important ones are the neuraminidase inhibitors and the cap-dependent endonuclease inhibitors. The mechanism of action is a little bit different. The neuraminidase, as I mentioned before, the virus infects the cell here. It attaches through the hemagglutinin to the sialic receptor. It gets internalized, it multiplies, and then when it's going to bud off that cell, the neuraminidase comes like a scissor and cuts that protein, that virus loose, and that's how the virus can infect the other cell. We have 3 neuraminidase inhibitors in the market, oseltamivir, zanamivir, and peramivir, and we have 1 cap-dependent endonuclease inhibitor, which is baloxavir. And the way these baloxavir works, it's basically on the replication and transcription of the virus. It inhibits that phase of the viral replication, not the budding out of the cell. Who should you treat? I have my personal opinion, and there's guidelines. Let me give you the guidelines. So your treatment should be provided for anybody at high risk of complications, and we'll go over that on the next slide. Anybody who's being admitted to the hospital with a confirmed or clinical diagnosis of influenza should be treated, and treatment should be started in the emergency department, not wait for the patient to get to the room. Anybody who has been diagnosed with influenza and is progressing, then you should get antivirals. And this, I want to make something very clear here. This is regardless of the time of symptoms. There's a confusion in many providers that have interpreted that you have a 48-hour window. It is true that the earlier that you treat a patient, the better the outcomes. But when a patient is getting complicated or has high risk of complications, even if it's after 48 hours of initiation of treatment, all the guidelines recommend to start an antiviral. Now, if you run into a fellow who or lady who is young, does not have any comorbidities, the data only shows that the antivirals will maybe cut the duration of the flu maybe for a day or a day and a half. That's the impact. It's not going to change their mortality or their hospitalization rates, because these people usually don't get complicated unless you're under a pandemic, and that's a different story. The pandemic viruses are very aggressive with young, healthy people. But if that young person lives with grandma, you could consider treating that person to decrease the viral shedding and preventing or decreasing the risk that that young individual infects grandma and kills grandma. So there's a lot of grandma killers out there that they don't know it, because they come with the sniffles to the home after they had a flu, they infect the grandma, and then they say, oh, my grandma died of a pneumonia. I don't know what happened. Yeah, I can tell you what happened. You had the flu and you didn't get vaccinated, you didn't get treated, and then you gave it to your grandmother. So that's another indication for treatment. Or if the household has an immune compromising condition, it's also, you could treat the index patient. Okay, the last bullet here, treatment decision should not wait until laboratory confirmation. That is also true, unless you have a laboratory result within 30 minutes. I mean, the patient's not leaving, he's going to be there. Okay, wait for the lab test, and then you can treat him. But if you are very convinced that they have the influenza and the lab test is not going to change your mind, then you just go ahead and treat him. The lab test result, I meant. So these are the complications, and you know them very well because you've been dealing with COVID for 3 years, and it's basically the same thing. You know, very young children, especially when they're younger than 2, they're at high risk for complications. If you're older, if you're immune compromised, if you're pregnant, and then certain ethnic groups like Native Americans, Alaska Natives, extreme obesity, etc. And anybody with a chronic condition. I'm not going to mention them. You have them on the slide here, but anybody with a chronic whatever, unless it's a chronic callus, everything else applies, and they should be offered treatment. Okay, let me try to summarize the 4 antivirals so you are able to select which is the most appropriate one for your patients. So let's start with baloxavir, which is the endonuclease cap inhibitor. It inhibits viral replication. The beauty of it, it's an oral single dose. It's only 1 dose and you're done for the whole treatment. The problem with it, it's the cost, and not all insurances will cover it. It's only approved for 12 years and older. I think, I'm sorry, I think I need to correct this slide. I think it has been approved, and Whitney's going to check for me while I'm finishing the talk, the baloxavir indications of the peds population, because I think they dropped it to younger individuals. It is FDA approved. It is not CDC recommended. That sounds like counterintuitive, but the CDC does not recommend it because there's not as robust data as there is with oseltamivir, not because it doesn't work. The CDC prefers oseltamivir, which interestingly is not FDA approved for the treatment of acute uncomplicated influenza. So this also sounds counterintuitive. Why? Because the FDA approved oseltamivir for patients with complications, because those were the first studies that got the FDA approval label, and then that label was not updated. But the reality is that both of these antivirals work, and the choice should be based on age, and should also be based on access. You know, if you have if you can have the 1 dose, it's better than treating someone for 5 days. The other thing that baloxavir seems to work much better for influenza B compared to oseltamivir. So if you know what type of influenza your patient has, or if you know that the outbreak in your area is due to influenza B, baloxavir may be a better choice. Then peramivir is intravenous, so we hardly use this at all. The only indication to use it would be in someone that cannot take a pill. Let's say they're vomiting, they're very nauseated. So you could give them in the emergency room of 1 single dose. Now it's hard to run, it's hard to get. We tried to get it once, I remember, in one of the epidemics, and we really actually couldn't get it. And zanamivir is an inhaled antiviral. It's twice a day for 5 days. You have to be 7 years or older. And it's contraindicated if you have asthma or COPD, because the excipient that it comes with can increase your cough and can cause bronchospasm. So in summary, we have 2 oral ones. One's 1 single dose, one is 5. One is better for influenza B. One has more robust data. Peramivir is intravenous, only in case that someone cannot take a pill. And zanamivir is inhaled, which is a decent option, but there's not, there is some data that I'll show you on this one. So this is a very loaded slide, but all these 4 studies have been evaluated in uncomplicated influenza in low-risk patients, and they all show similar results, which shorter time to alleviation of symptoms, of which zanamivir was the one that was associated with the shortest time of alleviation to symptoms. You're usually saving a day or a day and a half of symptoms, unless you started really early with the treatment. And baloxavir was associated with the lowest risk of influenza-related complications. But all of them show the same things: decreased duration of symptoms, decreased risk of complications. And when they looked at high-risk patients, same deal. All of these drugs, except for the second part here on baloxavir that was not assessed, the hospital stay, they showed all these antivirals, if you give them the sooner you can, they have an impact on preventing complications in high-risk patients. And when they're compared to each other, they're very similar. There's not a big difference, except for baloxavir has more activity against influenza B in one study. So these are the complications of influenza. You can have bacterial infections in your sinuses, in your ear. There's cases of myocarditis, very similar to COVID. Actually, there's a very interesting study that it increases the risk of heart attacks. And actually, there was a study published in Annals of Internal Medicine a few years ago that showed that influenza vaccination had a higher impact in preventing heart attacks compared to statins. So, everybody gives Lipitor to their patients to prevent a heart attack, but not everybody vaccinates their patients for influenza. And it is very important to vaccinate patients who are at risk for cardiovascular diseases, because this exacerbates the risk. And it's basically thought to be through a mechanism of immune activation, pro-inflammatory state that causes endothelial damage and plaque rupture. Of course, pneumonia is the most dreaded one. Patients who get a viral pneumonia are usually extremely sick, and many of them die. And then you have some other rare, but once in a while we see encephalitis, aseptic meningitis, Guillain-Barré. I've met several colleagues and patients who have had Guillain-Barré secondary to influenza. And then, of course, people can die from this disease. 40,000 people a year average die from it. So it's not a benign disease. This is a study that compared baloxavir with oseltamivir versus placebo for patients at high risk of influenza complications. And what they found is that both antivirals were better than placebo, but when they separated the group that had influenza B, oseltamivir actually did not have a lot of activity on influenza B in this particular study. So you look time to alleviation of symptoms, oseltamivir for influenza B was 100 days, placebo 100 days. I'm sorry, hours, not days. And influenza B was 74 days for baloxavir. So there was a decrease in the duration of symptoms and also viral shedding when on the patients on baloxavir. So this is just one study. And you may take it as it is, but it's just a consideration. So, question for you guys to think about. 70-year-old man with COPD presents with symptoms indicative of an influenza, but is stable for outpatient treatment. I mean, patient does not need to be admitted. Which antiviral would you recommend for this patient? So I'll give you 15 seconds to think about it, and then I'll discuss each one and tell you what the right answers should be. Okay, I did not measure my 15 seconds, but I kind of assumed that they're already gone. Baloxavir would be a good option. It's 1 pill a day. So it would be the best option if you think that that 70-year-old patient would not be able to, for whatever reason, take the 5 days of therapy if you were going to use oseltamivir. But oseltamivir would also be a good option. So between baloxavir and oseltamivir, there wouldn't be a difference. Both would work. We're assuming this is influenza A. If it was B, I would choose baloxavir. But if it was A, either or are fine. But it will boil down to coverage. Nobody's going to pay $200 for influenza treatment out of their pocket. So if the insurance covers it, fine. If it doesn't, you have to use oseltamivir. Peramivir is intravenous. So this patient, it's not mentioned that she can't eat. So there's really no indication to give her an IV dose of peramivir. Zanamivir is inhaled, but remember, you shouldn't use it in patients with COPD or asthma. So it would be a contraindication in this patient. And treatment not indicated, that's wrong. Treatment is indicated because this is a 70-year-old with COPD, has age and chronic conditions. So in summary, either baloxavir or oseltamivir, depending on adherence and coverage, would be the correct answer. So just a few things on children. Children should be vaccinated, very similar to COVID, when they're 6 months or older. For first-time vaccinations, they require 2 doses separated by 4 weeks. And that's only that first time. On the next year, they just get, the usual yearly dose. Children have a risk for complications. The benign ones that are not that benign are, bacterial infections, sinuses, ears, but they can have the pneumonia, encephalopathy, and it's worse if they're less than 2 years old. It's very important to vaccinate the moms during pregnancy because it'll protect that kid during those first, 6 months of life. And American Indian and Alaska Native children have higher mortality, statistically speaking. We don't know why. And also children with chronic diseases have more morbidity. So treatment considerations on, Whitney, were you able to find out that baloxavir age? Because I think it had dropped.
Yeah, so it's healthy children age 5 to 11, symptomatic less than 2 days.
Okay. All right. So so oseltamivir, you can use it if you need to, actually at birth, if you need to, although the FDA has approved it for 2 weeks or older. Baloxavir, 5 years or older. And then peramivir, you have to be 7 years or older. And azatanavir, I think it's 7 years or older. So there is room for all these drugs in pediatrics. So again, you would see, can the kid swallow? And if the kid can swallow, you would have, depending on the age, you would have baloxavir or oseltamivir is a good option. And if they can't swallow, then that's where peramivir could be helpful. 1 IV dose, especially if they're young kids that could be at high risk of morbidity. Okay, this is a critical slide that I do want you to remember. So this study looked at early presentation, diagnosis, and treatment of influenza, improve outcomes. So this is the reduction of days of illness based on the timing that you took the antiviral. So if you're lucky enough that you took the antiviral within 6 hours of getting infected with influenza, the median duration of symptoms, it's about 3 days. But if it's 12 hours, it's a little bit longer, 110 hours. And if it's more than 24 to 36 hours, it's 127 hours. And if it's 36 to 48 hours, it's 180 hours, which is about five days of symptoms. So you can really cut the infection by treating people early. And I can testify on this. I got infected with an influenza patient, and I knew about it the same day because I tested the patient came in and coughed in my face. It was a little kid. And I tested myself, and I'm sorry, I didn't test myself. I tested the kid. The kid had influenza A. So I don't know if Whitney was there, but I asked someone, give me a pack of oseltamivir, because I was traveling to Argentina the next day. And when I was in the plane, I started with fever and chills. Suddenly, boom, I took the oseltamivir, and believe me, in 48 hours, I was fine. And it usually takes me 5 or 6 days to get over a flu episode. So the shorter you start treatment, the better. Now, this is difficult to do because first, patients don't know this in general, and they either will not go to the doctor or will go late. And second, many doctors don't know this either, and they won't even prescribe an antiviral. And by the time they prescribe it, then the patient goes to the pharmacy, you have your 36 or 48 hours have gone by. But if we could shorten this, I think we could make a good impact. The 3 big societies, CDC, IDSA, and Pediatric Society, they all recommend that you should treat as early as possible. But if the patients are very sick or have comorbidities or are being hospitalized, you should treat them no matter how many days they've been sick with an antiviral agent. So remember, the 48 hours is ideal, but it's not 48, it's after 48, you don't get antivirals. I'll just drop this slide real briefly. I think if we could use telehealth to immediately diagnose patients, because like I said, if you're in an epidemic and a patient calls you and you immediately connect with them and I suddenly start with fever, I feel, headache, myalgias, and you're in flu season. Of course, it could be COVID too, but you immediately can say, okay, I want you to come in, get tested, and start and you can give them a prescription and then call the patient back when you have the test result. If you're going to get it in within an hour, of course. There's always antigen tests for COVID that they could do it, themselves and rule that out for the most part. But if we could have a telemedicine, that would be much faster. Patients are obliged to go to the emergency room, and they don't want to be there for 8 hours. So we need to fix the system by improving this. So prevention measures, you have vaccination. Vaccines are between about 40 to 50% effective. It depends on the match of the virus and the year. for preventing infection, but they're very effective in preventing mortality, very similar to COVID. You may still get the flu, but you probably won't die from the flu. There is chemoprophylaxis, meaning you can give antivirals to a certain group of patients. And then the germ etiquette, hand washing, covering one's cough. And I forgot to put a face mask. I apologize. Face mask will protect you from influenza. And then social distancing. So updates on flu vaccine, very short. I mean, Harry's the expert here. I'm just giving you a two or three liner. Who to vaccinate everybody 6 months and older. Timing September, and well, we're already in October, so September is gone. But you could have started vaccinated in September, but right now should be a good time to vaccinate. Remember that kids that have never been vaccinated need 2 doses, and the second one's 4 weeks apart. And until when to stop vaccinating? Well, it all depends on how the season's going. As long as you're having the influenza season is on, you can vaccinate. And even if it goes into April or May or June, you can still vaccinate. But when the health department tells you influenza season is over, then that's the time you stop offering the vaccine. If someone got let's say someone comes in February and says, but I got the flu in January. Well, they could have gotten flu A, and now we have a flu B going around. So even if they had the flu, it's still worth to offer them a vaccine. So the composition of the vaccine for this year has changed for the A component, for the H1N1. Remember, vaccines work better at preventing death than infection, but you still have 40 to 70% chances of less chances of being hospitalized if you're vaccinated compared to people who are not vaccinated. And the societies have dropped the egg allergy restriction. I mean, they say if you have an egg allergy, you may receive the flu vaccine, egg-based or non-egg-based. So, if you want to be careful and you have a non-egg-based, give that to your patients so they feel better. But there's actually no recommendation to do anything different, because it appears that there's really no difference on the, even if they have a true egg allergy, the data does not reveal that these patients will have higher risk of developing anaphylaxis or anything like that because they get the vaccine. I'm not going to go over this, but I have it there for you to review if you want to. These are the vaccines recommended this year, and you have high dose quadrivalents, normal dose quadrivalents. Give me 1 second, I need to pull this out of my way. And basically, the high dose vaccines are given to people that are older than 65. There's some data that you get a better immune response, or people who are immune compromised. And the rest I'll leave for you to review. One important thing that I found was this. So, estimating vaccine coverage needed for seasonal and pandemic situations. So if you have a seasonal epidemic, it is estimated that you need in the individuals that are 6 months to 64 years old, you need about 40% of the population covered to have a good impact in decreasing the transmission of influenza in your community. And of the older people, 58% should be covered. But if you have pandemic flu circulating, like H1N1 that we had in 2009, the number is much higher. You need 90% vaccination on this, especially on the younger population, and 100% vaccination on the older population. So that's when you really have to get up to speed on your vaccination. Unfortunately, my prediction is that if we have a flu pandemic 2 years from now, we're going to have 50% of the population wanting a vaccine and the other 50 not wanting them. And those are the ones who are going to die. I'm here in Boston right now at the ID Week. I just came from a symposium, and one of the researchers mentioned they looked at deaths caused for lack of COVID-19 vaccination, and is estimated to be 200,000 people that died for lack of COVID-19 vaccinations. And the greater proportion of these people were in Republican states. And the driver was listening and following the recommendations of Fox News. Just FYI, I'm not giving any political advice here, but that's a fact. So that was measured, and they looked at why these people did not get vaccinated, and the majority responded that's what they heard in the news. Anyways, so you can watch Fox News, but get vaccinated for influenza and for COVID. Okay, so a knowledge check, seasonal influenza is recommended every year for all age groups except children less than 6 months, 6 months to 18 years old, 18 to 49, or older than 65. So remember, the only contraindication, the only not indication for vaccination if you're less than 6 months old. Everybody else can get a flu shot. Very similar to COVID. I don't have it. How much time do we have? I have a few more slides left, but I can really summarize them.
We have until 12:30, but people have been dropping off. I think they probably were only available for an hour, but you have time. You're fine.
Okay, I'll make it short and sweet. So there is indication for post-exposure prophylaxis, meaning someone got exposed to the flu, but is not symptomatic yet, and you want to prevent that flu from happening in that person. So it's basically used in institutional outbreaks, especially in nursing homes, or in very high-risk individuals who cannot receive the vaccine or who may have received it, but you think they will not respond because they're very immune compromised. Or like they got vaccinated within the last 2 weeks and they still don't have an immune response. So to give you an example, okay, nursing home is simple. There's an outbreak in a nursing home and you can give antivirals to the rest of the asymptomatic people to prevent them from getting infected. Or you have cancer or in dialysis and have COPD, you got vaccinated a week ago and someone in your house came with the flu and exposed you, you could give that patient post-exposure prophylaxis. But it's not recommended for widespread use. And it's definitely here, the 48 hours do apply. If the exposure was more than 48 hours, then it won't work. So do not give it. This is not a substitute for vaccination. It's only indicated in the 2 situations I mentioned. And these are the 3 drugs that have been studied for post-exposure, which is oseltamivir, baloxavir, and zanamivir. And I'm not going to go into details, but there's room to use these 3 drugs depending on the situation for post-exposure prophylaxis. In my opinion, the easiest one, if economically viable, is the baloxavir, because you take 1 dose and you're done. The other one, oseltamivir, you have to take 5 days, and same for zanamivir. So last slide, common questions that you will run into is, why do I need to be vaccinated every year? And I hope that after this presentation, you can tell people is because we want to keep you alive. And we don't want you to be part of the 40,000 dead or part of the ones who infected grandma and killed grandma with the flu. The other one is, does the influenza vaccine cause the flu? I get a lot of questions about this, and some are not even questions, there's like statements. So it does not. You're not injecting live virus, except for the nasal and viral influenza, but it doesn't cause the flu either. But on all the injectable vaccines, these are genetically created proteins of the virus. Can I still get the flu if I have been vaccinated? The answer is yes, but your chance of dying or being hospitalized are much lower than if you don't get vaccinated. And if I had already had the flu, should I still get vaccinated? And the answer is yes, because we don't know if you had flu A or flu B, and usually on the seasonal flus, you have both strains circulating at different times. And that's why they should get vaccinated. And that's it. I don't know if anybody has any questions in the chat. Okay, oh, that was what Whitney put in the chat. Okay, if there's no questions, I think we can wrap it up.
Yeah, thank you so much for a great presentation. Again, if anyone would like to give feedback or get continuing education units, the link is in the chat. November's infectious disease echo is canceled. Our next one will be December 8th, and Dr. Mara will be presenting for us on HIV. And the recording will be shared with you all. Thank you so much.